Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, everyone, and thank you for joining us for Conversations in Acute Myeloid Leukemia, Novel Therapies Targeting the Immune System for Elderly and Unfit Patients. During this segment, we'll be discussing novel therapies that target the immune system. I'm Dr. Dan Pollyea. I'm a professor of medicine at the University of Colorado in the Division of Hematology, and I'm joined today by my friends and colleagues, Dr. Tapan Kadia and Dr. Eunice Wang. So guys, I think this is an area of a lot of reasonable enthusiasm, but also, some significant concerns. Tapan, do you want to just sort of talk first about, on the concern front, why it may be that AML patients would not respond well to an immune-mediated approach?
Yeah, Dan, thanks. I mean, like you said, the immune system, the immune-mediated approach in AML is very, very enticing, and we really want it to work, but for so far, we've seen lots of challenges along the way. We know that, for example, after allogeneic stem cell transplant, we do get some GVL or graft versus leukemia effect, that the T cells from the donor may be helping prolong remissions in our patients who get transplant. And we hope that with our new therapies that are available and that are becoming available, including PD-1, PD-L1 antagonists and various antibodies, that we can actually sort of harness that immune system without doing a stem cell transplant to still maintain good responses. But it turns out that AML is a different beast, a very different beast than, let's say, even ALL, distant cousin in leukemia. And the fact is that the AML has multiple issues. Number one, what is the target in AML? As in ALL, we have CD19, which seems to be a very novel target, even CD20, which you can target completely and not worry about B-cell aplasia because it's not necessarily life-threatening. You have a great target that's stable. We don't have such great targets in AML. We look at CD33, which may be present on a portion of the cell, CD123, but also present on other cells, so you get sort of off-target toxicity. Sometimes you lose these antigens, so you have clones that escape. And then most primarily, you have a really sort of immunosuppressive bone marrow microenvironment where AML tends to colonize and segregate. We know that there are increased myeloid-derived suppressor cells, which can actually thwart a lot of the T-cell activity. In fact, this was one of the reasons to use PD-1, PD-L1, but it didn't work out. There's a lot of upregulation of PD-L1 in AML blast, which actually thwart and lead to exhaustion of the localized T-cells. There's infiltration of Tregs in the microenvironment that can prevent the immune system from activating completely. So there are a lot of challenges in not only the target, but also the microenvironment that we're treating that actually inhibit a lot of our immune therapies from working well. But, we've got some good leads, I think.
I agree. And on that front, one area to discuss would be, the potential for CD47. And so when we're talking about CD47 mediated approaches, we're kind of talking about harnessing the innate immune system. And I find this fascinating, and and maybe this is our way in AML, but the idea essentially is that CD47 gives off it's responsible for a quote unquote "don't eat me" signal, and that's kind of what allows cancer cells that overexpress this to evade detection by the innate immune system, specifically the macrophages. And so, it's now been shown in multiple cancers, including AML and MDS, that CD47 is overexpressed in those situations, and that can that can potentially be one of the contributing factors to this disease ability to sort of grow and spread. And so, a lot of the preclinical data around interrupting CD47 and then allowing these tumor cells to be recognized and sort of neutralized by the innate immune system was really pretty compelling and exciting. And so, Eunice, have you had any direct experience with the use of any of these CD47 blocking agents? And if so, what's been your experience with them?
So yes, thanks, Dan. I would agree. The theory and the thought that we could harness this unappreciated arm of the innate immune system for AML therapy was extremely exciting and very novel. And the data was really outstanding in these preclinical models. So we were part of the original phase 1 study looking at the naked CD47 antibody, the magrolimab, and combined with azacitidine, based on the fact that in preclinical models, azacitidine would upregulate CD47 expression and therefore make the magrolimab that much more effective by allowing that mechanism to be much more pivotal for the survival of those AML cells. And so that particular antibody had a unique side effect because it turned out that senescent red cells also expressed up high levels of CD47. So when one combined azacitidine with the magrolimab, we did see an acute hemolytic reaction, which occurred in probably 10-20% of our patients with the initial dose. And that led to even acute drops in their hemoglobin of 1 to 2, even 3 grams. And you can imagine these elderly unfit people with some underlying comorbidities, cardiovascular and pulmonary, that there were some significant consequences to that acute hemoglobin drop. So with some additional red blood cell phenotyping and having those units available and sort of preparatory, maybe transfusing the patients in advance, we were able to make our way through that toxicity, which did, just to be honest, lead to some deaths. However, the initial data showed that this immune pathway might be particularly active in patients that have p53 mutant disease. And as we all know, p53 mutant AML, particularly with high variant allele frequencies, with double p53 mutations, and with complex karyotype, is a horrible subset of AML and is found potentially an increased frequency in our elderly and unfit individuals who may have a secondary AML. So we were initially extremely excited to see median survivals, response rates 50-60% in p53 mutant, as well as survivals of 10 to 12 months in early phase data. And we were excited to take the drug into 3 phase 3 studies, ENHANCE-1, ENHANCE-2, and ENHANCE-3, looking at the combination of magrolimab azacitidine versus azacitidine alone and high-risk MDS and p53 mutant AML, and then a combination even combining it with venetoclax azacitidine in ENHANCE-3. Unfortunately, we did, and those studies still have issues, maybe the same issues you have in a multi-center study where you have increased toxicities. But unfortunately, both ENHANCE-1 and ENHANCE-2 have subsequently been closed because interim analysis have shown no difference in overall survival endpoints as compared to azacitidine alone. Now, that data is still in press release form. We don't have the actual subset data. That hasn't, however, diminished our enthusiasm for this pathway, potentially maybe not that drug. So there are other different agents. There is a Pfizer compound. There are other drugs that are trying to not only target using a naked antibody against CD47, but try to activate that SIRP alpha pathway on macrophages by binding and activating FC receptors on the macrophages via a dual activation approach. There might be better antibodies to CD47, small fusion proteins that again might more potently activate that arm of the immune system. So I don't think that we've given up completely on that. But I think some of our enthusiasm initially has been a little dampened by, as always, a negative phase 3 randomized controlled trial.
Yeah, thanks for that really nice detailed answer. It really, shows your kind of involvement in this project for a really long time. Tap, do you have any thoughts on the construct here, like an antibody versus a fusion protein, and what impact that might have on efficacy or toxicity?
Yeah, no, I actually, we've used both. We've used magro. Obviously, we see a lot of hemolysis, as you said, in some patients who have these senescent red blood cells. We've seen less hemolysis with SIRP alpha binding drugs. So I think toxicity-wise, those they're interacting with SIRP alpha, which is on the macrophages and not on the red cells per se, leads to a little bit less hemolysis, but you're still activating the CD47 SIRP alpha pathway. Whether it's an antibody or a fusion protein, it's not clear that there's any difference yet. I think the schedules of the drugs can be a little bit different because of the size of the drug and how often you have to give it. So those are the differences, but we haven't seen much yet in terms of differences in those, except for the hemolysis and less toxicity with the SERP alpha engaging drugs.
Thanks. Let me stay with you, Top, on the next topic I wanted to talk about in this sort of neighborhood, and that's the idea of TIM3 inhibition, and specifically the drug sabatolimab, which is under development.
Yeah.
Any thoughts about the impact of this target? It's sort of where it fits in the immune therapy landscape, and what you think about it, future for drugs that target this.
Sure. I think there was a lot of excitement about TIM3. So TIM3 is another one of these sort of immune checkpoint or immune dampening type molecules, right? They're present on T cells, they're present on macrophages, it's present on Tregs, it's present on NK cells. And so what TIM3 does is TIM3 interacts with a protein or one of the ligands is galectin-9. And when it interacts with that, TIM3 then sends a signal to whether it be the NK cell or the cytotoxic T cell, the macrophage, to sort of reduce the immune response. And so if you have TIM3 that's present on these and it interacts with the galectin-9 that's present on the malignant stem cells or the malignant tumor cells, in this case leukemia, then you'll have sort of a dampened effect. And in a way, the leukemia is protecting itself from immune attack by sort of stimulating TIM3. In fact, TIM3 also, I think, binds to phosphatidylserine, which actually activates the immune system. So it kind of sops up phosphatidylserine and doesn't allow T cells to get activated. So in general, it's sort of an inhibitory immune kind of protein. Now, if you had an antibody, sabatolimab, that blocks TIM3 and blocks this interaction with galectin-9, then potentially you can have an activated immune system, whether it be T cells or macrophages or NK cells. I think one of the advantages or what seems nice about this is that it's on so many of these different immune cells that you can sort of target all of them and have activate the entire immune family, if you will, in the microenvironment to attack the malignant cell. And so it was first studied in MDS, right? Because there was a lot of excitement in MDS, and unfortunately, the MDS study has not borne out positivity in terms of activity in MDS. That being said, I think there's still potential for acute myeloid leukemia. I think there are several studies that are going on, including one that's going to be presented at ASH. That's looking at TIM3 in the setting of what I discussed in a different podcast about sort of minimal residual disease, sort of in the setting of where there's very low burden of disease in a maintenance setting or even post-transplant. And so there's a study, I think it's an oral presentation, looking at post-transplant sabatolimab to sort of augment the immune system that's left behind. So the donor immune system to try to provide surveillance for any residual AML cells that are left behind. So I think there's still maybe some potential to combine TIM3, the sabatolimab, with things like azacitidine or other immune therapies in patients with low-level minimal residual disease. But I think it's an interesting target. Lots again, as Eunice pointed out, there have been several large studies, including one in MDS, that didn't sort of meet what we wanted to see. So there's been some dampening of enthusiasm, but I think we need to keep pushing.
Yeah, I agree. I think, it's yet another strategy to sort of awaken the immune system to kind of help eradicate the tumor, and the extent to which our patients have that capability, especially in the multiply relapsed or heavily pretreated areas, is rightfully a question. But perhaps, like you suggested, we should really think about this in low-level disease areas. Maybe that is, something within the power of the patient's immune system to sort of work out. And as you said earlier, a great example of this being a successful strategy in general in AML is the fact that there's a graft versus leukemia effect when it comes to allogeneic stem cell transplants. So just in the remaining minute or so, I'm very intrigued by specifically trying to weaponize NK cells. So we've had a little bit of discussion about this leading up to now, but there are some abstracts last year or so, and now some press releases too, showing some activity. Eunice, do you have any thoughts on this as a strategy, sort of adoptive NK cells, and how that might have a future in our field?
Yeah, I think that we've been a little bit, as you said, disappointed. I don't think we need to give up on some of these macrophage or other TIM3 approaches. I mean, I think that the early FLT3 inhibitors, of which nobody knows their names anymore, were completely ineffective, and now we have very potent FLT3 inhibitory targets, inhibitors for us. So in terms of NK cells, I think that there's been a lot of data, a lot of disappointment with the T cell directed or T cell activating approaches, mostly because we think these elderly unfit people probably don't have very potent T cells. They're exhausted, they're T regulatory, they're suppressed by MDSCs, as Tap mentioned. So there just might not be an active enough T cell component in these patients inherently, intrinsically, to really be stimulated by even our most potent approaches. So looking at other arms of the immune system, the NK cell arm is not HLA mediated. It's an arm that's very active against viruses and infectors, and it's incredibly potent. And we have found, and you mentioned recently, abstracts for the harvesting and infusion of activated NK cells, CD56 positive, with or without interleukin-2, harvested from normal donors or even placental sources, actually have demonstrated efficacy in terms of blast reductions and responses. And this is something that seemed like sort of like an outlier approach. You know, we were really T cell focused for so many years, given the success in the solid tumor world, that this was sort of like, well, why, and what are NK cells? But now we're coming back and saying, you know, in myeloid disease, the T cells are maybe not where the money is. And when we think about our therapies and we think about the immunosuppression that our patients face, it's largely in that T cell component, right? And so we can't necessarily fix the Tregs and the MSTCs and the exhaustion, but if there is an active functional NK cell cellular therapy that we could use, that may be where the true immune active therapy lies. The other approach is, I know that people are trying to put chimeric antigen receptors into NK cells to make them even more potent. Or maybe if the patient's own T cells are not potent enough, we could do CAR T therapy, just like we do for ALL. So I think there are people that are still trying to salvage that T cell approach and translate it into myeloid malignancies. But I don't know whether that's really the way to go. I mean, we have to go where the biology of the disease leads us, not where we think it should, right? What are your thoughts on that? I mean,
yeah, no, I think you're absolutely right. And it'll, we'll kind of continue on this path. And, the last 5, 6, 7 years, we've found success and by doing just that. And so I'm optimistic that that'll continue in the future. But this was just a great discussion, everyone. Thank you so much. And thanks to our audience for joining us for this segment on novel therapies targeting the immune system in AML. And please be sure to click on the landing page for this activity to claim your continuing education credit, to access supplemental slides, as well as other topic segments. Thank you guys so much.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.